It's a pleasure to be speaking on this topic. Again, a very rare topic for us to be managing in private practice, institutions, of course. And it's so good to have institutional tycoons sitting here in the audience. We definitely will have some inputs from them also. So, if we look at the history, the first case of calculus in the graft. Now, calculus in the graft, as understood, was probably if it is diagnosed pre-operatively or probably in a transplanted kidney. So here I am discussing graft which was transplanted, and we encountered a stone in the transplanted kidney after some time of transplantation. So the first case that was mentioned in the literature was in 1977 in the Journal of Urology, and the mode of diagnosis was quite primitive by today's standard. It was a 1.5 centimeters calculus in the renal pelvis, presented with UTI and microhematuria, creatinine of 1.1. The UTI was treated with ampicillin. The IVP showed a calculus in the pelvis. So what they did was a surgery, a pyelolithotomy. The pelvis was closed with 40 chromic catgut and the drain removed after 48 hours. Patient went home healthy, and the creatinine at discharge was 1.5. That time the limitations which we very easily nowadays have by bedside: no ultrasound, no Doppler, no CT scan to map the renal vessels and their relations with the stone and the other important structures in the abdomen. No higher antibiotics, no pigtails, no DJ stents, no ureteroscope, no flexible ureteroscopes. So today's urologist can probably imagine how difficult it was to be encountering such patients in those era. The clinical features, incidence wise, if we see now, the incidence mentioned in literature is 0.46 to 1.7%, lower than the general population, which is normally 6 to 12%. However, in this type of patients, the incidence is underreported, as the kidney does not really evoke any symptoms. The kidney is a denervated organ, and there is no perception of pain in such kidneys. So, for a long time, the kidney stones go undiagnosed. There are very few publications, and whatever are there are very small study sizes and short observational periods, so no definitive protocols could have been formed. They can cause acute kidney injury and CKD, and may lead to ESRD through obstructive nephropathy or crystal nephropathy if the patient does not really present with any drastic symptoms. Now, the causes and risk factors, generally speaking, these are the causes that have been enlisted, but they may not be true in the transplanted kidney. Presentation is usually incidentally diagnosed on a routine follow-up, which can manifest in the form of a rise in creatinine, which is observed in 17%, gross hematuria as in 10%, UTI 9% patients. Pain forms only 3% of patients. Normally, we take a transplanted kidney stone to be presenting like a patient with a solitary kidney, usually present with anuria and severe pain. But in such patients, the pain forms only 3% of the symptom complex. The mean time interval from transplant to nephrolithiasis was observed to be about 28 months. One has to have high index of suspicion, which is necessary due to insidious presentation of the anomaly. Now, treatment. Today we have a big spectrum of treatments available, which we can offer to normal patients, but for the treatment of kidney stones in a transplanted kidney, there are various limitations, and not all of these can be applied. If we look at ESWL, then the therapeutic strategies, they closely mirror therapeutic strategies for management of a transplant kidney stone. They closely mirror calculi in a solitary kidney in non-transplant individuals. If we look at ESWL, it has a significantly diminished role due to the problems in accurate localization by virtue of the kidney's location in the renal pelvis. The shock waves are obstructed by an overlying bony pelvis from all the sides. Sometimes, if at all we manage a ESWL, the fragmentation is usually not complete and auxiliary procedures have to be applied. So this is a less preferred modality now. Flexi URS, that is a most preferred thing, and probably with the type of finesse we have now with urologists all across the country, this should be a very preferable option. However, the durability and maneuverability has made it the durability of FlexiORS and maneuverability has made it an excellent option for allograft kidney stones with diameter of up to 1.5 centimeters. For larger stones, clearance may pose a problem, but somehow they are also cleared in a staged the FlexiORS procedure. And the presence of disc and the fans access sheath nowadays has made even larger stone clearance quite effective. So for PCNL, this is the most commonly applied procedure for kidney stones in a transplanted kidney, usually suitable for calculi in the renal pelvis or in the proximal ureter. However, one is handicapped by the placement of the kidney, lack of knowledge of the placement of the kidney, because the CT scan may reveal the location, but most of the times the relation to the vessels remains ambiguous, and so planning the tract is also a tricky procedure. Most often, one has to approach from the superior or the middle calyces. It's preferable to follow a staged procedure, I feel, whenever we are attempting a PCNL in a graft kidney. We should have it a staged procedure, unlike the normal PCNL, which is a totally retroperitoneal procedure. In a transplant kidney, it is more likely to be through the peritoneum also, one cannot say. So what I would advise is one does a PCN to begin with, and after about 3 or 4 days, once the tract has formed well, he does go inside and again attempts a second stage of PCNL, wherein the stone can be definitively removed. A stent is always preferable to place in the post procedure period, and combination with ultrasound or fluoroscopy is preferable. So with all these modalities, what we are still in dark about what is the ideal way. We can never define a single best modality to treat such stones. They are usually associated with acute kidney injury, which complicates the whole scene, and one has to decompress before actually going in with a definitive treatment. The graft functional status may vary. Sometimes it may present to us with some amount of renal insufficiency already there besides the AKI. He may have a creatinine of 2.5 or 3, and with that the stone may present to us. The ureter usually runs an unnatural course which cannot be defined by any amount of CT expertise. The ureteric orifice for a retrograde instrumentation is very precariously located and very variably placed, difficult so many times to locate, and even if it is located, very difficult to enter. The retrograde access for rigid URS is difficult and often impossible. You may have to place the patient in the prone position also, usually very easily manageable in female patients, but in male patients, the length of the urethra makes it difficult. The antegrade approach may not allow access to the entire ureter, although the proximal half can be definitely accessible. So one has to be prepared and be quite well versed with combined antegrade and retrograde techniques. Usually preferable to have two urologists working at both the ends. The FlexiORS can't always enter retrograde, as I mentioned earlier, nor can it always traverse the entire length of the ureter either way, from above or from below. The rigid URS is more unlikely to access more length. However, for stones in the lower half, if the orifice is entered, then it becomes quite easy. In my practice of so many years, I have had only one patient in 30 years, which was a patient of a live-related transplantation. He was about 55 years old, presented about 6 years after the transplantation. The nephrologist diagnosed a marginal rise in creatinine, so an ultrasound was done. We showed a moderate hydronephrosis and calculus in the lower ureter. The CT scan films are shown here, shows the calculus in the juxtavesical ureteric region. And this patient also had stones in the native kidney. It was full of stones, but they were asymptomatic, so they were left alone. The patient age was 61 years, not 56. So I tried to do a URS. The calculus was located just near the ureteric orifice, and on entering the bladder, it could be found at the meatus of the ureter. Fragmentation was attempted, but the entire stone migrated proximally, so I placed a DJ stent. 1 month later, when a CT scan was done, the calculus was again seen at the orifice. Repeat URS was done. Fragmentation was possible this time. I did not dare to remove the stent. With the stent only, I tried to fragment. Half the fragments could be removed. The other half again went up. And so I retained the stent inside and sent the patient home in the hope that the remaining stone would be probably smaller, and since it had almost reached the orifice, the remaining half would just come out. But after 1 month, the stone was still there. So this is the procedure, the video which shows the stone at the meatus, and fragmentation was done. And you can also see the stent in the low 6 o'clock position. So some fragments could be brought about and some fragments then flew up. 15 days later, antegrade flexi URS was done through a PCN. A PCN was done, and after 4 or 5 days, I did an antegrade flexi URS. Here, that time we did not have the disposable URSs. So this video shows the URS went up to the bladder, and on retrograde pulling it out, the stone could not be localized, but I could not see the stone, so I was not convinced whether I have removed the stone. An accident happened while pulling out the flexi URS. Even the guide wire slipped out, and so I was left now without a stent and without a PCN both, and in a quandary whether the stone is out or not. I presumed it was inside only, and it was inside. After 24 hours, the patient had anuria, and as you can see here, he had a bloated abdomen full of urinary ascites, and the stone very much inside at the lower end of the ureter. The urinary ascites I had to manage by placement of a pigtail catheter inside the abdomen. The patient decompressed like a balloon in about 2 days. The creatinine also dropped down to normal, and there was no sepsis fortunately. The native ureteric stone was visible on CT scan. After 1 week, the abdomen stabilized with a nephrostomy inside the abdomen. Creatinine also settled down. PCN retained for another week. A CT scan was repeated after 1 week, and fortunately the stone had passed out. And patient also gave history of passing urine perurethral despite the PCN being inside. So creatinine dropped from 1.4 to 1.1 in 1 month, and probably I was taken care of. The stone was taken care of by fate. This is another example wherein a deceased donor kidney had a large calculus. Nobody was willing to take this calculus. Nobody was willing to take the kidney with the calculus. 71-year-old one recipient accepted this stone. I removed the stone, closed the pelvis, and transplanted this kidney into her. And today, after about almost 2 years, she is hale and hearty. That's all about it. Thank you.